So very good afternoon to all of you. It's my pleasure to be here. I thank the chairpersons for the invitation, for the introduction, and the organizers for having invited me over here. I also thank Dr. Sashank for having given a beautiful lecture on secondary diabetes, which also makes it easier for me to talk about endocrine hypertension, because he has, to a large extent, also talked about diabetes being due to those endocrine causes and given some background about what is the presentations, so it'll be easier for me to take it from there. So my talk over the next 20 minutes is basically on endocrine hypertension. When we talk about secondary hypertension, which is different from endocrine hypertension, we talk about renal causes, neurological causes, and of course endocrine causes. The reason I put this slide up when my topic is endocrine hypertension is the most common cause of secondary hypertension is renal, and we should never ever forget that. And this particular session is very useful because as busy clinicians and physicians, we very often forget about that there may be some other cause either for the diabetes or for the hypertension itself. So renovascular hypertension is almost as common as 15 to 30% of all patients with hypertension, which is, and especially the younger hypertensives. So at this particular point of time, I'd like to say that this is a very simple test. You have to do non-invasive tests to see that there is no secondary cause, for especially renal. There's a simple test called the renal Doppler, and you can look at the renal artery, which is maybe a single artery or both the arteries may be stenosed when you're looking at hypertension. In case you're not able to get any definite idea with the renal Doppler, you can do a functional scan, which is a renal scintigraphy. And the most common that we use is this DTPA scan, which will tell about the functionality. In this particular scan, you can see that there is a delayed excretion of the dye and at the pelvic calyx. So you know that there is hypertension due to the kidney. Having said that, I rest my case on renal because now I will talk about endocrine causes of hypertension. So apparently, endocrine causes of hypertension occurs in at least about 10 to 30% also of hypertension in younger individuals. There will be adrenal dependent causes, which is the pheochromocytoma, primary aldosteronism due to hyperdoca, which could be also due to congenital adrenal hyperplasia. Only few varieties of congenital adrenal hyperplasia have mineralocorticoid associated hypertension, like 11-beta hydroxylase and 17-alpha hydroxylase. All the other common garden variety 21-hydroxylase don't present with hypertension. So if you have a CAH which has hypertension, you should think, are we looking at 11-beta or a 17-alpha hydroxylase deficiency? If there is a DOCA-producing tumor, primary cortisol resistance, Cushing's syndrome, 11-beta HSD deficiency, and we also know about thyroid. Hypothyroid will cause diastolic hypertension. Hyperthyroid will cause systolic hypertension because of the mechanism. In hypothyroid, there is increased peripheral vascular resistance, and in hyperthyroid, there is increased cardiac output, thereby causing hypertension. And there is a parathyroid dependent causes and pituitary like acromegaly. I won't go through the last segment in detail because they're very obvious when it comes and we do screen. But I will be talking about pheo and a primary aldosteronism in detail. So now who should be tested? Should we test everyone? No, it is very cumbersome and very not cost effective to test for everyone. Young individuals, patients who have high blood pressure, which is not coming down in spite of 3 antihypertensives, or they're controlled with more than 4. And if there is a diuretic-induced hypokalemia, please think that this could be endocrine hypertension. And if it's associated, just by and large, think you did a CT abdomen, you found an adrenal incidentuloma, patient says, I have sleep apnea, because very common with hypothyroid, family history of early onset hypertension, you should think that we are looking at endocrine hypertension. So let's start with Cushing's disease or Cushing's syndrome to start with. So, like Dr. Sashank has already said, there is ACTH dependent and there is ACTH independent. Why is this important? Because usually we will do ACTH along with cortisol, and at that particular point you will understand whether you're looking at a pituitary cause or an adrenal cause, because if you know where you're looking, you may image or you can treat accordingly. And the other important thing is these are all treatable causes. If you do surgery, they can completely reverse the hypertension. So why does Cushing syndrome or Cushing disease cause hypertension? There is increased vasoreactivity to circulating vasoconstrictors. These excess cortisol, when the cortisol is more, it also works on the mineralocorticoid receptors. So that is why in the initial stages, if you just give glucocorticoids, it's enough, and that will also work as a mineralocorticoid. There is decreased endothelial nitric oxide synthase activity. There's increased hyperinsulinemia, and there's augmented renin substrate production in the liver and increased intravascular fluid volume. Thereby, all of these causes the hypertension. Manifestations I won't go through because I think you have seen this in Dr. Sashank's slide again, but basically there are general, skin-related, neuropsychiatric, very often depression, emotion lability. It should make you think, are we looking at something else? Musculoskeletal, gonadal dysfunction, especially women with menstrual irregularities coming with diabetes and hypertension, please think Cushing's. And metabolic, if you're finding that there is diabetes, hyperlipidemia, polyuria, kidney stones, one should think of higher cortisol levels. So what do? How do you screen them? In our own center, we usually do a midnight cortisol and an overnight dexamethasone suppression test. You can give about 1 milligrams of dexamethasone late night, and you can look at the cortisol early morning. If it is less than 1.8, then you're nothing to worry about. All the guidelines have changed. Earlier it was 5, now it is 1.8. So if it is less than 1.8 micrograms per deciliter, there is no hypercortisolism, but if it's more than that, you need to check. And in the midnight, if the patient is awake, which mostly they will, because you're going to go and, even if he's sleeping, you will go and poke a needle into his arm, he's going to get up, and there anything less than 7.5, there is no hypercortisolism, and if it's more than 7.5, we should think about it. So now if you have to decide whether it's ACTH dependent or ACTH independent, and then search. First you have to do it biochemically, assess and establish, then image. So if it's an adrenal, you'll do a CT scan, and if it's a pituitary cause, you can do an MRI. Supposing MRI draws a blank, you should think that it's an ACTH dependent ectopic Cushing. So look at the lungs, do an X-ray of the lungs to see if you can pick up the ectopic ACTH secreting tumor from any of those places. The next common and very, very common, more common than Cushing, is primary aldosteronism. Very often if you get a low potassium, one should think, am I dealing with hyperaldosteronism? What are the subtypes of primary aldosteronism? The commonest are these two: aldosterone producing adenomas, which are about 34%, and the bilateral idiopathic hyperaldosteronism, which is 65%. All the rest, whether it's familial hyperaldosteronism, less than 1%, there are type 1, type 2, type 3. And if there is unilateral adrenal hyperplasia, again less than 1%. But you should think about it. But most commonly will be the APAs and the IHAs. So how does it happen? Usually in the normal mechanism, the angiotensin 2 makes the potassium channel close, thereby the calcium channel opens, and this is controlled, and there is depolarization depending on the need, and you will have aldosterone synthase. But supposing there's a mutation like in the familial type 3, then what happens is a constitutive depolarization and constitutive cell cycle activation and uncontrolled proliferation. What does that mean? Continuously there is stimulation, continuously there is aldosterone synthase production, and there is increase of aldosterone synthesis and release all the time. In mineralocorticoid excess, what should you do? Immediately at baseline, you should do a renin and you should do a aldosterone concentration. I recently got a young lady, about 21 years old, her aldosterone concentration was 84. Referred to me incidentally by a nephrologist. He said she is having high aldosterone and her blood pressure was very, very high, sent to me. So the investigation was not complete. So we did a PRA, that is the plasma renin activity, or you can even do the serum renin per se. It was also high, thereby showing that this was not a mineralocorticoid or a aldosteronism excess. So you should have a suppressed renin and an increased aldosterone to say that this is primary aldosterone. You can't just look at one aldosterone and say this is primary aldosteronism. So if you have a low renin, high aldosterone, you have primary aldosteronism, and all of those are mentioned there. And if you have low renin, low aldosterone, and yet a high BP, you're looking at congenital adrenal hyperplasia, Licorice, Little syndrome, so many of the others which are mineralocorticoid excesses. So what should you look at? Hypokalemia, hypertension, and sometimes they also come with end organ damage because it has gone unrecognized for long. Especially aldosteronism may not come with very, very high blood pressures. Most of the time they do, but may not also be. They have a little bit of cardiovascular risk. They can cause LV mass greater and LV dysfunction, myocardial infarction, atrial fibrillation. So how should you measure? First and foremost, there will be hypokalemia that should be corrected, following which they should have liberal salt intake, and if they are taking any of the drugs which interfere with that, you should stop them. And then any beta blockers, NSAIDs, spironolactone, all of that you should stop, and then you should collect the mid-morning blood after being upright for 2 hours, and you can do the aldosterone levels. And supposing it comes high, the aldosterone is very high, and the ratio is also high, you may not do a confirmation test. But if you are a little bit doubtful, are you going the right way, you can do a confirmation test. Most of the tests are also a little bit difficult and risky to do. What we do in our center is an IV saline loading. It's the most simplest one to do, where we give normal saline 2000 within 4 hours, and then we measure the plasma aldosterone levels. This is a simpler test to do. To do the fludrocortisone suppression test, and already the blood pressure is so high, is really, really risky, and I have never done it myself. So once that is confirmed, then you'll have to do an adrenal CT. The important thing is, if there's a unilateral hypodense nodule, even it's unilateral, and you find that is hypodense, if it is less than 40 years, you can do a unilateral laparoscopy. But if it is more than 40 years, in spite of it showing only on one side, it may actually be the opposite side which has the tumor. So you will have to do an AVS, that is the adenovenous sampling, to understand where is it, lateralize it. Sometimes, very often it happens. You may see one side, but the other side is producing, and then go ahead and do surgery. And if you have normal CT, or it is micronodular or bilateral, and there's a low probability of an adrenal producing adenoma, you may think of IHA and do pharmacological therapy. If there's a high probability, you should still go and do an adenovenous sampling. And if there's no lateralization, then you don't do anything. But if there is lateralization, you will have to do a surgery after that. So this is how it would look. The adrenal gland is compared usually with the diaphragm. If the limb of the thing, you can see those arrows, if the limb is thicker than the diaphragm, then you should think that it is enlarged. So what we usually see is you can actually make out also what kind of nodule you are dealing with when you're looking at the adrenal scan. So if it is more than 15 Hounds units in unenhanced lesion, this is a lipid poor adenoma or a malignant lesion. And if you have dynamic contrast, the mass attenuation of 80, and here you have delayed washout. So all this also tells us. I'll show you one on FIO, which will make you understand better. So how do you do it? Of course, you have to do surgery. Indication of surgery is APA, unilateral adelectomy is done. Before that, you may give spironolactone for some time to see that their BP is well controlled. And mostly they are normalized, but hypertension may persist in a good 30 to 40% of patients. Then we come to cortisol excess, we finished aldosterone, and last we come to catecholamine excess. 85% of all FIOs arise from the adrenal medulla, and some of them, 15%, are extra-adrenal also. They need not always be from the adrenal medulla itself. So you can have paragangliomas, and these are all little rare tumors, and they all arise from the chromaffin cells. All of this you must be knowing. They cause sustained hypertension because of high catecholamines, norepinephrine, and they can also cause orthostatic hypotension. Sometimes there is a reduction in the blood pressure in different parts of the day also you can have this. This is because of decreased blood volume caused by consistent vasoconstriction and diminished sympathetic reflex. So you should be aware of this also. So again, they will come with headache, sweating, typical paroxysms, which we call. They'll have typical paroxysm with every flush of the catecholamine that's getting released, palpitation, tremors, dyspnea, weakness, panic attacks. So very often we may just say, oh, it's panic attack, especially if the woman is 40 years old, panic attack, she's going into early menopause or something like that. It should have a high degree of suspicion. Atypically, it can also have a hypertensive crisis, unexplained heart failure. You give them because of the BP, you give them some beta blocker and they may actually land up in hypertensive crisis, because for a few you should alpha block first before you go into beta block. And in a newly onset diabetes, in a young lean hypertensive, you should think of whether you're dealing with endocrine hypertension or pheochromocytoma. Whom to evaluate? Those who have hyperadrenergic spells, who have family history. Pheochromocytoma is most of the time familial also. Pressor response during anesthesia, surgery or angiography, and those who have dilated cardiomyopathy of unknown cause in a young individual. Also look that it could be a men-to-be syndrome. So where you'll have neuromas, ganglioneuromatosis, medullary thyroid carcinoma, skeletal abnormalities, marfanoid hepatitis. So this is associations. You can have neurofibromatosis type 1, which you should have more. Many of the times we'll have cafe au lait spots. We have not looked for it so many times, and that too in our skin color, it's very difficult to identify these cafe au lait spots. But if you just go back and to your clinic and see from tomorrow, you will be able to see cafe au lait spots in quite a not a quite number, but at least in some number of patients. They may not be symptomatic, and it should be more than 6. It won't be 1 or 2, there'll be many more. 2 or more dermal neurofibromosis, osseous lesions, family history of neurofibromatosis, Lisch's nodules, freckles in the axillary region, and optic pathway gliomas. So these are associations of pheochromocytoma. And this is the syndromes, and why we learn of syndromes? If you see a syndrome, you see a pheo, you have to see that you're not missing a pituitary, you're not missing a pancreatic tumor or a medullary thyroid carcinoma, because these are all go in hand, and you should understand that these can happen along with that. So once we know that, then you have to subtype the pheos and the paragangliomas, and then you can have familial paraganglionoma type 1, type 2, and then we do the succinate dehydrogenase subunit gene product, and then look at where is the tumor. If you know this, you can know where to look for the tumor, because they all occur in different places. So this is how it would look along the extra-adrenal region throughout the sympathetic pathway. Wherever there are chromaffin cells, you may get them. So if you suspect, what do? We usually do fractionated metanephrines. Now we get serum plasma metanephrines also. So you can do either urinary metanephrines or you can do plasma. And if there are more than 4 times elevated, there's a strong possibility, and then you have to image. All endocrine problems, first biochemical testing is must. You should not go directly to imaging, because you may find a tumor, but it may be an incidentaloma. You may have it high and you may have a tumor, but it may not be the cause. Very often you will have prolactin high and you'll see a small tumor in the pituitary gland and you'll think it's a prolactinoma. It may not be so. It may be just an incidentaloma, and here you have prolactin levels little high. So it's very important to have a high biochemistry and then look at the tumor. We usually do an MIBG scan, but you could also do a PET if there's some MIBG may not show all the time. It's not so simple. the endocrine tests we do. Cushing's disease sounds so easy when we are talking, but we actually need to do so many repeated tests because we don't know where the tumor is. And though it looks simple, it is a lot more difficult to identify and to image and to find out where the lesion is. But we have lots of imaging modalities like PET scan, Octriscan, and contrast CT at our available to us to identify it. So this is how I was telling you. If you look at this adrenal looks quite different from the adrenal that I showed you before. This has a pre-contrast attenuation of 10 Hounsfield, and then if you look at the contrast, it is more than 80. And have a 60% washout of contrast. So you can actually, looking at the adrenal, make out the difference. I won't go into treatment medical. You can give alpha blockers. Once they are adequately blocked, give them beta blockers. And then give them enough, make up enough of plasma volume, it will be constricted. And then only plan for surgery, because just touching the tumor during surgery can precipitate a hypertensive crisis, and you may lose the patient. It's a difficult one. So to conclude, endocrine hypertension forms about 10% of all causes of hypertension and about 40% of young hypertensives, and it is a treatable cause. Aldosteronism is the commonest cause, and we all need to have high degree of suspicion to understand whether we are dealing with endocrine cause of hypertension. Thank you very much for a patient hearing.